name is Sheila Nyabisi Aiko, a pediatric nurse at Moi Teaching and Referral Hospital Eldoret, working in the neonatal unit. For this study, we are looking at the patterns, risk factors, and the treatment outcomes during acute phase hospitalization of children under the age of 5 years at the Kenyatta National Hospital. So when you look at congenital heart diseases, these are structural and functional problems that are brought about by malformation that happen during development phase, which occurs by the gestation of 12 weeks, and this affects the normal functioning of the heart. And when we look at the data available, we see that in Kenya there is not much information, but regionally we have Namuyonga, who has done a lot on congenital heart diseases from Uganda. And an estimated 500,000 children are born with CHD every year in the sub-Saharan Africa, where Kenya is one of them. And when we look at Kenyatta National Hospital, we could only find one journal, which was done by the Kenyatta Cardiac Care Unit in 2021, and they did a mention that there was a burden of neonatal mortality and child mortality that was increasing due to CHD. And this increased focus will bring about the increased access to high-quality pediatric cardiac diagnosis and treatment. We are looking at SDG 3 in this conference, and if we address these congenital heart diseases, we will be able to meet SDG number 3, which aims at ending preventable deaths in neonates under 5 years. Our broad objective is just a paraphrasing of our topic, and we divided it into 3. That is the risk, the patterns, the risks, and the treatment outcomes. The methodology, this was a retrospective case control study. So where we sampled files, 2,450 files of children who had been treated in Kenyatta National Hospital during the period of 1st January 2017 to 31st December 2021, with their matched controls but not matched for age. And we were able to get a concentration at 1720, which is 20% of the total sample size that we had been given from the records department. The sampling method was the census, where we studied all the files we could reach, and the data collection was done using a data abstraction form. The area of study, the records department at the Kenyatta National Hospital. So the data analysis was done by the SPSS version 25, and it was presented through the frequencies and percentages, charts, and graphs. So we used the chi-square and odds ratio at a level of 5% significance level to be able to find the association between the variances. The ethical considerations, we asked for permissions from several authorities. The KNH ethics department to be able to give us the permission to do the study. Then we further got permission to collect data from the cardiac department, the pediatric cardiac department, and the head of records department to be able to get the data. On the results, we saw that we divided our results into 2. So over the 5 years of study, we saw that there was an increased trend of both the cyanotic and acyanotic over the 5 years, with majority of them being the cyanotic. And when you are in the clinical area, you'll notice that it's very difficult to diagnose a cyanotic CHDs. Then on the risk factors, we realized that diagnosis made after infancy brought out not a good outcome. That on the children, the infants' Down syndrome and prematurity were significantly seen to be of not good outcome. and we can see the statistics there. Then the cyanotic CHDs, they are easy to diagnose, but they take the clients down very fast. So on treatment outcomes, we had to compare these treatment outcomes in the CHD group and the control. The controls were those without CHD, but remember we said we did not match for age. So the patients, we had a total of patients of 218 who died in the 218 patients who died in the CHD group compared to 173 in the non-CHD group. So you see the percentage difference is almost double. Those who recovered, by recovery we mean they did not have complications, they got their treatment interventions, and they were able to be discharged home in good health. And that is a total of 87.3% against 92.1% of the non-CHD group. So those who died after infancy and during infancy, now that we saw that diagnosis after infancy was a major factor, those who died after infancy were 147, which is higher than at 67.4% as compared to those who died during infancy at 32.6%. So when we look at it, that upward trend over the 5 years was also seen by Namuyonga and Tomford, both in 2020. Those were studied, they did. The interventions that were seen to be working for them, thank you, were the cardiac catheterization, medication, oxygen therapy, and this was also seen by other studies. The risk factors associated with these poor outcomes were demographic factors. We've seen the age less than 1 year, and then we have also seen Down syndrome and prematurity. Then the mortality rate, the mortality rate of the CHD, we've seen it at 70.2%, which was higher than their non-CHD counterparts. And we also saw the poor outcome of those diagnoses made after infancy. So in conclusion, we saw that there was an increasing trend of prevalence of CHD over the 5-year study period. A cyanotic was more prevalent than the cyanotic. Other factors that were seen to be more associated with the risk factors were high maternal BMI, maternal multifetal pregnancies, maternal alcohol and drug abuse, and there was also the Down syndrome and prematurity in the children. So we saw that children with cyanotic congenital heart disease on an average had a 3 times higher odds of dying as compared to those with an cyanotic CHD, and the children with CHD had a 1.5 times higher odds of dying, and infants, Down syndrome and prematurity were the 2 risk factors that were highly associated with poor treatment outcome. The recommendations were evaluation of the risk factors associated with the increasing trends and patterns of CHD among the children at KNH. These will be able to identify and give prompt and early intervention to improve the outcome. Sensitization of the staff to be able to diagnose the CHD early, defects early, since most of them are cyanotic and they lack the obvious clinical presentation. Then there was the antenatal staff should do risk stratification so that we can be able to pick out the mothers, like those who had the maternal high BMI and those with alcohol and drug use, so that we can be able to curb and prevent these risk factors before they lead the CHD early, and improve the capacity to manage children with a cyanotic CHD to reduce the mortality, with greater focus on children with the 2 conditions that were with the poorest treatment outcome. For further studies, we had requested that they do a prospective study so that they can assess both the acute phase and the long-term care outcomes of these children. Thank you.